Hi, my name is Emanuele. I hereby present my final exam as a social and health assistant. These quotes summarize the main challenges in the care of my Parkinson's patient, the requirement for mobilization to prevent functional loss, and the requirement for disease-specific education, which is essential for professional sparring and early detection. This work consists of three parts. In the first part, I briefly present how Parkinson's disease occurs and affects the nervous systems. I introduce Knoll, my care patient, his challenges, and how the medical staff responds to them. In the second part, I show how I, as a caregiver, have responded to these challenges and illustrate my concrete actions. I conclude this part with a nursing professional evaluation, which is based on Orlando's nursing process. In the final part, I take a critical view of my actions and introduce alternative approaches that could have helped in handling these challenges in a different way. Parkinson's disease is a neurodegenerative disease. This means that the neurons die. These are the neurons that secrete dopamine in an area of the brain called substantia nigra, or black substance. More precisely, the parts compacta inside the substantia nigra. Dopamine neurons are black, and when they die, the substantia nigra loses its typical black color. What happens when the substantia nigra secretes less dopamine? The arrows here, here, and here indicate that the neurotransmitters receptors respond with an excitatory stimulus. And the bars here, for example, indicate that the neurotransmitters receptors respond with an inhibitory stimulus. The striped lines here, and here, for example, indicate a decreased activity. Doubled lines indicate an intensified activity. Dopamine is marked here with green color. In case of reduced dopamine, the dopamine receptors do not respond sufficiently. Striped lines here. For example, the acetylcholine neurons are not modulated or inhibited, and the too strong acting acetylcholine gives the typical Parkinson tremor. The GABA interneurons have only an inhibitory function. This inhibitory function is either understimulated due to a decreased dopamine receptor excitation, and the GABA interneurons therefore do not inhibit sufficiently. Or the GABA interneurons are not sufficiently inhibited, like here, for example, due to a decreased dopamine receptor inhibition, and the GABA interneurons inhibit too much. The resulting cascade effect decreases the natural inhibition of the subthalamic nucleus, which becomes hyperactive. This results in an excessive inhibition of the thalamus. The following signaling weakening from the thalamus to the cortex motor centers provokes Parkinson's main symptoms, such as bradykinesia and rigidity. Aggregation of alpha-synuclein proteins are typical of Parkinson. In a certain way, they resemble the well-known Alzheimer's plaques. These aggregations that reach the gut via the vagal nerve explain Parkinson's influence on the enteric-nervous system, with symptoms in the peristalsis such as delayed gastric emptying and constipation. Parkinson's disease affects all nervous systems. For example, the modulation of blood pressure with problems such as neurogenic orthostatism. The disease is incurable with progressive motor impairments and terminates in the fifth and final stage with full and palliative care corresponding to ICF level 4. Levodopa. Levodopa is given as therapy as this is converted into dopamine in the CNS. Here you can see the difference between a Parkinson's patient without and a Parkinson's patient during levodopa treatment. Levodopa cannot stop the neurodegeneration of the substantia nigra. The striped line indicates a deficiency, but the dopamine receptors react with normal inhibitory or stimulating effects. The normal inhibition of the subthalamic nucleus, we can see here the difference to the Parkinson patient that doesn't get a levodopa treatment, is re-established, and thus the signaling from the thalamus to the cortex motor centers is normalized. Parkinson's symptoms subside, and levodopa thus only works against symptoms. And here we have Knoll, 81 years old. He has got a Parkinson's disease diagnosis 20 years ago and is in levodopa oral treatment. Knoll is discharged from the hospital to a rehabilitation center after a successfully treated pneumonia. As a caregiver, I am challenged by the function loss after hospitalization when I read the conditions recorded by the home care unit before admission. Knoll could move around with a walker and can now only be mobilized with a lift and steady. The level of consciousness is reduced. Blood pressure is low and he is permanently somnolent. Before hospitalization, he only had to be motivated to eat, and he now needs meal assistance due to dysphagia and a reduced mobility of the upper limbs. Inhalation drugs, beta-2 agonists and anticholinergics have become ineffective against this snow. Knoll is so pain-marked that he cannot be mobilized the first few days. The challenge is, how can we best help Knoll? Should we get Knoll back to the conditions before hospitalization, or should we accept a Parkinson's-related irreversible deterioration? Knoll was discharged from the hospital with infectious pressure ulcers. I order an anti-decubitus mattress and pressure-relieving heel pads. If, however, he is not mobilized quickly enough, complications of bed rest arise, the short-term consequences of which can become serious. With a drop foot, he may never walk again. I apply Antonovsky's sense of coherence theory, OAS in Danish, and Vygotsky's zone of proximal development, NUZO in Danish. I divert his chronic fatigue with trips on the wheelchair to stretch the time he spends sitting, but I must give up when he gets too exhausted. This condition first requires medical evaluation. Knud's general practitioner halves pain medication dose, thus aiming at improving consciousness level and respiration. He adds glucocorticoid inhalation, SPN, in addition to the glucocorticoid regular medication. He refuses to lower the antihypertensive drugs, beta-1 blockers, due to 3 previous bypass surgeries. The doctor affiliated with the rehabilitation center adds a fluid intake scheme against hypotension, and the neurologist increases the macro goal regular dose by 50%. This is precisely the intervention of the neurologist that led me think that the problem lies in levodopa's absorption. I look at the medication chart and realize that a large part of levodopa is given during noon and evening administration rounds. That means simultaneously with food intake. The Danish drugs repertory recommends a levodopa intake 30 minutes before or an hour after food intake. Levodopa is used instead of dopamine because levodopa is an amino acid and utilizes the dedicated amino acid transports to pass from the gut into the bloodstream and then to pass the blood-brain barrier to enter the nervous system. If levodopa is consumed simultaneously with protein-containing food, the dietary amino acids will outcompete levodopa in these transport mechanisms. Levodopa's plasma concentration will drop and the Parkinson symptoms will appear. This hypothesis can be recorded as an action hypothesis in a nursing process. I can't offer low-protein food to Knull because of Knull's current weakening. I choose to postpone Knud's meals 30 minutes after the noon and the evening drugs administration rounds and give notice to all shifts. Levodopa's bioavailability should thus reach the 98% indicated in the drugs repertory under optimal absorption conditions. We have seen that the neurologist increases the macro goal dose by 50%. This intervention leads me to think that constipation may reduce the effectiveness of levodopa. Knud's levodopa medication are combined with benzerazide, which inhibits the enzyme decarboxylase, which is the enzyme that converts the amino acid levodopa into the neurotransmitter dopamine. Thus, levodopa can only be converted after passing through the blood-brain barrier that benzerazide cannot pass. The literature shows that prolonged permanence in the gut leads to levodopas being prematurely converted to dopamine. Levodopa therefore becomes ineffective as dopamine cannot cross the blood-brain barrier. Constipation has therefore a major impact on levodopa's pharmacokinetics. What does constipation look like in a person with Parkinson? Parkinson's effects on the gut can be very peculiar. During a healthy defecation, the puborectalis muscles relax. These open the angle of the ampulla recti from a right one to an obtuse angle. Thus, the force of gravity of the feces is directed vertically towards the anus and can facilitate the passage. In Parkinson's disease, the puborectalis muscles react paradoxically. They contract the ampulla into a right angle instead of relaxing it. There is a relationship between body position, hip flexion, and the angle of the ampulla recti. Knoll, for example, cannot defecate in bed. When the body lies in bed at a straight angle, the ampulla recti lies at an acute angle, which makes defecation difficult. When Knoll sits on the WC in a 90 degrees hip flexion, the angle of the ampulla recti opens to no more than 90 degrees before muscle relaxation. In a squat position, where the hip flexes at an acute angle of, for example, 45 degrees, the ampulla recti angle opens to a straight angle where the feces gravity force vertically presses on the anus. This hip flexion and the resulting natural angle in the ampulla helps against the paradoxical muscle contraction in Parkinson's disease. There are now two action hypotheses in the nursing process. One targeting levodopa pharmacokinetics and one targeting Parkinson's paradoxical muscle contraction of the puborectalis muscles. I can't expect Knoll to sit on a squat toilet, but a toilet stool squat like this one is enough to reach a hip flexion at an angle that is less than 90 degrees. Bobat's natural or normal patterns must be put into perspective historically. Economic and cultural development has introduced convenient but not healthy toilet habits. The squat position is physiologically the true natural pattern. I now evaluate all interventions based on their results. Defecation normalizes, but the Parkinson's symptoms continue. In addition to that, the typical levodopa-induced dyskinesias occur. Why? What is the source of error? Literature shows plenty of algorithms that consider various gastrointestinal barriers to transport and absorption of levodopa. However, it is to suspect that this lack of response is not due to the gastrointestinal tract, but to the progressive neurodegeneration. Although the deficiency of endogenous dopamine release is compensated by the levodopa's exogenous dopamine, the effect will decrease when dopamine receptors are destroyed, because the chemical signal cannot elicit an electrical response in ion channels in the form of depolarization or hyperpolarization. Therefore, levodopa absorption could no longer be related to its efficacy. There is, in fact, a correlation between the extent of neural loss, the decreased response to levodopa, an abnormal neural adaptation, and increasing levodopa side effects in the form of dyskinesia. The progressive neurodegeneration in Parkinson's disease is followed by a corresponding reduction in the therapeutic index of levodopa, as you can see here, and in an increase in levodopa's side effects. This challenge can be tackled with a thorough approach. These require an investigative approach by caregivers in terms of monitoring, recording, and evaluation of symptoms for early detection and early initiation of tailored treatments. In this perspective, tools such as the motor diary, where symptoms here and side effects are hourly recorded, become essential. Data is electronically compiled and analyzed. This analysis of symptoms and side effects leads to CNUL being correctly placed in Parkinson's disease development in relation to levodopa's waning response. This analysis requires a strategic approach, such as the advanced care planning, which is used for incurable progressive diseases. This is the same as the early interprofessional care planning. In this approach, the patient's perspective and the biomedical perspective are united in an ongoing dialogue where actions, treatments, options, and wishes are discussed and translated into a plan. Important, however, is the timing. The advanced care planning must be initiated at a development stage where CNUL is still able to make decisions and where therapies can still be implemented. When CNUL becomes a partner in the process, he actively participates in a planning where all scenarios are discussed. We could have discussed with CNUL what alternatives are available when levodopa's effect wanes. One option would have been a non-pharmacological approach, such as deep brain stimulation. We can see here how the deep brain stimulation can compensate the lack of levodopa's response. To the left is the healthy impulse transmission. In the middle is the impulse transmission in Parkinson's disease. For example, when levodopa no longer works. When levodopa does not sufficiently provoke electrical responses, the subthalamic nucleus is not inhibited properly and becomes hyperactive. This means that it secretes too much glutamate. We can see the difference by comparing with the healthy impulse transmission to the left. This subthalamic hyperactivity overstimulates the GABA interneurons. We can again see the difference to the healthy impulse transmission. And the GABA interneurons exaggerate their inhibitory effect on the thalamus. The thalamus sends a weakened glutamate signal, we can see the difference here, to the cortex motor centers, and we have the well-known bradykinesia. How does the deep brain stimulation work? An electrode is surgically implanted into the subthalamic nucleus. The electrode's electrical impulses are inhibitory. This inhibition normalizes the subthalamic influence on the GABA interneurons. We can see that is normalized actually, and their influence on the thalamus. The Parkinson symptoms thus subside. The deficitary chemical efficacy of levodopa is replaced or compensated by electrical signals. Problem. Knoll is now too old for this surgery. It should have happened 10 years ago. This procedure should have been discussed in an advanced care planning approach many years ago. What options are available? The peripheral vibrotactile stimulation is a non-pharmacological and non-invasive solution that utilizes two therapeutic approaches: the focused stimulation through vibration and the rhythmical stimuli, otherwise called cueing. Both impulses are generated by a small device that is placed on the sternum. The vibrotactile stimulation consists of vibrations which are captured by the skin's mechanoreceptors and transmitted through 1-alpha neurofibers to the cortex with the effect of down-modulating the beta waves. The hyperactivity of the beta waves blocks the initiation of movements observed in Parkinson's typical festinating gait patterns. The vibrations stimulate the proprioceptive and tactile functions and put the body into the ready-to-move state that characterizes fluidity. The rhythmic cues imitate the brain's natural rhythmic stimuli for initiating movements, replacing the typical activity of the basal ganglia, bypassing even the Parkinson's affected area, and reducing symptoms. The solution is not invasive, is easy to apply, is not expensive, yet this is still in the testing phase. The idea originated in the 19th century with the French neurologist Jean-Martin Charcot, who observed that Parkinson's symptoms lessened when patients had traveled in a carriage that at that time produced strong vibrations. I now can conclude my presentation. I have shown that the challenges of Parkinson's disease, especially the progressive decrease of levodopa response, can and must be addressed in the framework of the advanced care planning strategy that best serves incurable progressive diseases. Caregivers must be trained in the specificity of the disease to handle the necessary observation and documentation tasks and support diagnostic work. This bibliography is only supplementary. A link to the complete bibliography list can be found in the commentary. I thank you for your attention and thank Knul for the incredibly instructive and professionally stimulating collaboration. To him, I dedicate my exam in the hope that research will immediately offer the solutions he needs.